Greetings, everyone. Welcome to the 168th session of the online Optom Learning Series, OOLS. And we are very happy to have with us Dr. Bina Patel for today's session. Dr. Patel is a professor of biomedical sciences and diseases and the director of the Center for the International Advancement of Optometry at the New England College of Optometry, which is NECO. She has a significant role in local as well as international teaching, particularly in the area of primary care optometry and also emphasis on ocular disease. She has published numerous papers as well as received numerous number of awards. The most prominent one I would just like to mention that she was awarded by the World Council of Optometry in the year 2015 as the International Optometrist of the Year. And today, Dr. Patel is going to take us through how do we perform binocular indirect ophthalmoscopy and how is this useful for an optometrist in a primary eye care setup to look at the retina. So welcome, ma'am, onto our platform. And, let me just leave the screen time to you.
Right. Thank you very much for inviting me to the series, and it's a pleasure. I know it's morning for me and it's evening or very late at night for you. So thank you again, and I hope I can put through some important points for examination of the fundus by the binocular indirect ophthalmoscope. So my goal today is to look over the peripheral retina and the anatomical landmarks that you'll see when you actually do binocular indirect. What is the instrument setup? What are the instrument features? How do you position the patient and the examiner? And then, what's the purpose of doing a peripheral retinal exam? What would be the flow if you were doing it on a patient? And then documentation of findings. So one thing I would like to say is I think binocular indirect ophthalmoscope is an instrument that takes a lot of practice to get very comfortable with and very familiar with. So it's probably one of the more difficult instruments as an optometrist that we would learn. And it takes a lot of patience to master, but also a lot of patience, as in seeing patients, to actually get very good at. And it should be part of our routine comprehensive eye exams. But again, we're limited if we cannot dilate the pupils, if we are not allowed to use the diagnostics. But it does provide a lot of valuable information, and it gives a thorough exam for the patient too. So just in highlights, the posterior pole, we always know that this is a very important aspect for us to examine when we look at a patient, is really the optic nerve head, the macular area right here, and the vascular arcades that make up this significant area, which on any new examination, on any comprehensive exam, we should really be examining very carefully. So with that, here's just an ideal picture where you have your nice optic nerve head, you have your macula a little bit more pigmented, you have the internal limiting membrane reflecting off it, you have a foveal reflex. It just sort of hints that this is a younger patient. And then you have the vascular arcades, and you can also see a little bit of the nerve fiber layer kind of coursing from the optic nerve head. So that's the posterior pole, and we know this is critical to vision. So when we think of the peripheral retina, we have to sort of understand what the equatorial region of the eye is. And this is demarcated specifically by what we call the vortex veins. And the vortex veins tend to be at 7 o'clock, at 11 o'clock, could be around 5 o'clock, could be around 1 o'clock. And they demarcate if we draw an imaginary line anterior to it, so a little bit further out of it, out of that circular area where my red dotted line is, that would be called the equatorial region of the eye. Now, the equatorial region of the eye, if we look at it in a cross section from front to back, this is the largest circumferential area of the eye. And again, the vortex veins will be just slightly posterior to that imaginary line that we draw, which is called the equator. And the importance of that is because that sort of demarcates part of one of the edges of the peripheral retina. So that starts the beginning of the peripheral retina and you go further out. Okay, so the vortex veins are part of the choroidal circulation. And so the blood drains through the veins, through the vortex veins, and then through the scleral canal. And these can be seen quite often in a fundus. And so when we see them, just sort of draw an imaginary line slightly anterior to that, and then you'll actually know where the equatorial region of the eye is. So we use it as a landmark sometimes to describe the location of a finding. We use it to sort of identify some of the natural findings of the eye that we see. So here actually is a very light fundus. And the point is that you can actually see quite a bit of the anatomy. The red vessels up here are more the retinal vessels. They're very well defined. You can see them very distinctly. And then because this patient has very little pigmentation, has a very light fundus, we can actually see the choroidal vasculature further down. And the vessels look a little paler, and it's because it's further down in the tissue. But actually right here in this area is where the vortex vein is, okay? So I think of the vortex vein, some people describe it like a little octopus or a little spider. It's got like a little roundish body like this, that's the ampule, and then the tributaries come out like that. And so that's why they kind of describe it like a spider or an octopus. So you can see here is the vortex ampule, and then here the tributaries are coming off, and that's the actual vortex vein. So we know somewhere around this area here is sort of the imaginary line of where the equator is, okay? So here's another one. These are just watermarks from the lens of the camera that took the picture. And right here, you can actually see those little tributaries coming across like this, and then a little bit of the body right there, and that's called a vortex vein. So this is a wide field camera. This is an Optos imaging. And again, this is going to revolutionize how we even look at images. This is non-dilated. This is a reasonable sized pupil where they've taken about a 200-degree field of view image. And it actually does a very good job, laterally. Vertically, it's got some of its limitations. But the point being that even if you could take photos and you could afford a camera like this, you should be able to identify what's normal and abnormal. So you can actually look right here where I'm pointing, and you can see this is a vortex vein, and it's got the little tributaries, and these are the choroidal vessels. They're not as distinct as the retinal vessels, which are right here. You can see that. And also as a note, as we get towards the peripheral retina, the retinal vessels kind of thin out and they almost parallel the ora serrata. So here's just another photo of the vortex veins. Okay. So when we think of the vortex veins, we look for the equator as an imaginary demarcation. And then going further out to the peripheral retina, we end up going to what we call the ora serrata. And that's where the retina and the choroid end. And the retinal layers become one single layer, and it goes into the pars plana. So the pars plana is the next structure, and that interdigitates with the ciliary processes towards more anteriorly. So the peripheral retina really is from the equator to the ora serrata, and it's about 40% of the entire fundus, and that distance is about 3 disc diameters. So when you think about it, it doesn't encompass a huge amount of the whole retina, but it does have a significance, particularly when we're looking for some abnormalities or some changes. This area to be examined is actually very important. Okay, so I will refer to disc diameters quite often, and it's just a concept. Okay, so what they do is we take the optic nerve head, and whatever size your optic nerve head is, we designate it vertically and horizontally approximately 1 disc diameter. And so you could have a slightly larger one. I could have a slightly smaller one. It's just an arbitrary term that we use just to designate a distance. And we think of 1 disc diameter approximately 1500 microns in size, okay? So when we look at a lesion like this, for example, we see something here like a choroidal nevus, we'll always reference it relative to a finding that is stable in the eye. So it's either an optic nerve or it's the macula. It could be the vortex vein, it could be near the ora serrata. And then we actually designate the size. And then we also designate the distance it is from the structure that we're referencing. So for example, here, this optic nerve head would be designated as 1 disc diameter. And this lesion is approximately 3 disc diameters away. So you imagine 3 discs going there. And then this lesion vertically is approximately 1 disc diameter in size and approximately 2 disc diameters in size. It's just an approximation. It is not, something that we need to, be so accurate about, like it's got to be like 1,000 microns or 1,500 microns, but it's part of, what we're looking at in general as a reference point and for documentation purposes. So some of the other landmarks that we may note when we examine someone with a binocular indirect and the peripheral retina is the long posterior ciliary nerves and arteries. And these are located at the 3 and 9 o'clock positions. We have 2, so you don't have more than 2. And they start from the ora serrata, okay, which is the termination of the retina and the choroid, and they kind of proceed towards the equator. And sometimes I've actually seen them come a little bit more towards the posterior pole. Nothing wrong, it's just a little more of an extended long posterior ciliary nerve. And they are horizontal. So if we drew an imaginary line between the 2 of them, it would sort of divide the retina into half. So we'd have a superior retina and inferior retina. It's a reference again. When we see the long posterior ciliary nerves, they usually look pale, faint, yellow in color, or maybe like a very faint, really like a very light color area. It's linear, so it's usually a straight line, and it's kind of thickish, so it's not very skinny, it's quite a little bit thicker. And again, it's a normal finding. Just trivia, the posterior ciliary artery runs below the ciliary nerve on the temporal side, and the artery runs above the ciliary nerve on the nasal side. And I'll be honest, we don't actually look for that. We don't really look out and say, oh, is the artery above or below? But we do see the ciliary nerve because it is an important finding to notice and then realize it's not an abnormal finding. It's just part of the anatomy of the individual. So here again, sorry for the watermarks here for the little white dots, but if you look out towards the periphery, you can see this sort of lighter area, and it's a long line. It's almost at 9 o'clock or 3 o'clock, depending on what side you're observing. It's pale, and it's starting from the ora serrata, and it's kind of aiming towards the equator. Okay, so here's another one. And you can see these are the retinal vessels, right? The choroidal vessels are underneath it. But right here, you can see sort of this linear streak. It's not skinny, it's kind of thick, and it goes right across, and it starts from the ora, and it kind of goes towards the equator, and that's the long posterior ciliary nerve, okay? So just note that there is that. Now, on the other hand, we also have the short posterior ciliary nerves and the arteries, and they're seen more in the superior aspects of the peripheral retina or inferior aspects, and then they're shorter in length than the long posterior ciliary nerve. So the long posterior ciliary nerve is quite long. These are shorter, and they tend to be found near the equatorial region towards the ora serrata, but they're slightly at an oblique angle. So you can get one at 1 o'clock or 11 o'clock, And they don't all have to be sort of vertical in its orientation. They could be slightly tilted, but again, linear. And they're a little thicker, and they're pale yellow or pale whitish in color. And we can have many of them. We can have, up to 8 or 16. We could have several, quite a lot of them. It's just not 1 or 2. So sometimes we'll see them in the inferior quadrants or superior quadrants. And then again, they're slightly at an oblique angle, and they're shorter in size, and they're kind of whitish or pale white or yellow in color. So just know that we have them. And here's just a photograph showing you these linear streaks. Again, they're quite thick. And again, their length is pretty short, and that's called the short posterior ciliary nerve. Okay. All right. So now the ora serrata is the anterior limit of the retina. And that's where anatomically you can have slight variations. So this is an artist diagram where the temporal edge of the ora serrata, where it, is more straight edged. Okay, so sorry. So this is the ora serrata right here. So it's more straight edged. And then on the nasal side, it's more scalloped. So it's more like this. Okay. And again, sometimes you will notice that when we're examining the peripheral retina. It's just a matter of knowing that that's normal. And this happens more on the nasal side, and then it's more straight edged on the temporal side. And that's just an anatomical variation. And again, we don't go looking out for it, but if we see it, if it's a little more exaggerated in an individual, we just know, okay, that's normal for them. So at the ora serrata, where you get this more scalloped edge, you get the retina interdigitating in between the pars plana, and this part that actually juts out like this is called the oral bay. And then the part where the retina is sort of interdigitating between the pars plana is called the oral tooth. Okay. And that's just, again, just some kind of anatomical information. But I think what's very important is this vitreous base. The vitreous base is very prominent finding in the peripheral retina. It means that the vitreous is very strongly adhered to that part of the retina. It extends a few millimeters posterior and few millimeters anterior to the ora serrata. So if this was my ora serrata right here, then the vitreous base kind of goes both anteriorly and posteriorly. And what it signifies is that the vitreous is strongly adhered to that area. And you might say, well, what's the significance of that? Is sometimes some retinal changes, retinal tears can happen quite close to the vitreal base. We should pay attention to that area as well. Okay, so and then this is just another artist diagram showing you that the pars plana interdigitates with the ciliary processes. Okay, all right. So here is another photograph of the peripheral retina. And what happens is, as we get to the end towards the peripheral retina, our pigmentation changes slightly. So the RPE layer, is a single monocuboidal area of pigment. And as we get to the periphery, it kind of flattens out. So it becomes a little bit flatter. So there's a little bit less pigment. Sometimes if we're, the whole retina may be a little more stretched in a myope, also that might change a little bit of the configuration of the pigment. So indeed, when you get closer to the ora serrata, when you're examining, the retina might get a little paler in color. It'll have less pigment. And that's because the RPE layer is still monocuboidal, still got pigment, but it's a little bit flatter. So there's less pigment. And then as soon as you hit the ora serrata, then you hit the pars plana, which is heavily pigmented, it's very darkly pigmented. And sort of in between that junction, you'll see sort of this straight line. Approximately, it's not a perfect linear line, and that would be the temporal side of the ora serrata. Okay, so you'll get normal retina, slightly a little paler towards the ora serrata limit. Ora serrata happens, and then beyond it, the pars plana is a little bit more pigmented. So here we have another picture where you can see the retina is fairly pink and then it gets a little paler. These are very subtle changes. Again, it's not gonna pop out at you right away, or you're gonna see it all the time, but you just gotta note that yes, it can be a little paler as we get to the peripheral retina. And then it's very dark here, and that's the pars plana. And you can actually see this area sort of jutting out. So this is the oral bay. And then if the retina is interdigitating, it's the oral tooth, right? And this is the pars plana. Here is, the retina. This is probably the ora serrata. And another interesting finding on this particular slide is you can see right here is the long posterior ciliary nerve. Okay, so it's coming out from the ora and it's going towards the equatorial region of the eye. Okay, so here we have a picture just showing you, here's the optic nerve head. Just to put reference to it, here is the macular area, right? Got your vascular arcades. You don't really see the vortex veins as easily as I showed you in a lighter fundus. And sometimes in a darker fundus, it's going to be a little harder to see because we have more pigment in the choroid, and that, and that kind of gives it a little bit of a darker appearance. But the goal here is to actually show you the ora serrata. You could see it's just going right here, and then you've got a straight edge, and then it continues on. So the ora serrata is sort of like a straight edge on the temporal side. Okay. This is another photo with a very dilated pupil, but what it's showing is, and again, to see this is not easy. Okay, so this is sort of like more somebody who was using it for teaching purposes. This is the ora, and then it's showing you the pars plana, and then it's showing you the ciliary processes being interdigitated with that. Okay. So this is an Optos, this is a wide field camera. This just happened to be one of the, pictures that did show it. A lot of times they don't get there depending on the pupil dilation and how you steer the imaging. But again, binocular indirect is going to get you hopefully to see a lot of the pathologies that you might need to observe in a comprehensive eye exam. So this one is just showing you sometimes what is our limitations based on pupil size, and what could we do, if we had the ability to do more with the patient's pupils. So the posterior pole optic nerve and the macular direct ophthalmoscope, 90 diopter undilated, depending on the pupil size, you can get a pretty decent view of the posterior pole. Yes, with a 90 diopter, you can guide yourself and do a little bit more in the periphery, but again, the pupil size is a limiting factor. But if we dilate, fully dilate, with the binocular indirect, you can get not only the posterior pole view, you can get to the equator, and we get to the peripheral retina. And that's very important. So there's a single best instrument to examining the peripheral retina and practical purposes is the binocular indirect. Okay. Now, one may argue if your pupil is dilated with a 90 diopter, can you get to the ora serrata? Probably not. You can get to the equator, maybe a little bit beyond, but it's much more difficult to get to the ora serrata. And with the binocular indirect, there's an efficiency involved with it. Okay, so I've talked for a bit, and so I have a question coming up. Just put it in the chat, and we'll just get some feedback from you. Okay, all right. So I want you to identify the structure A, pointed in the green arrow, and then structure B in the yellow arrow. So what I want you to do is just say A, what it is, and B, what it is. Give you about 30 seconds, okay?
Okay, great. So yeah, we'll wait for some feedback on the chat, and you can just type what do you think A is and what do you think B is, so at least we know. Okay, we do have a couple of responses. I think you can also see that as well. A couple of them are saying A is the vortex vein and B is the longitudinal ciliary nerve or ciliary vein.
Okay, all right, very good. So it's the vortex vein. And when I describe it like an octopus or a spider, it's more like a descriptor as opposed to the real name. And then this would be the long, right? So it's long, and then posterior ciliary nerve, okay? And so that's what it is. Let me see more messages. Yeah, that's great. Okay. And then again, you've got your posterior pole here, right? And this has got the macula and the optic nerve. So these are just landmarks that you'll actually pick up while you're doing it. And, you know, it's important to recognize that they're normal, okay? All right. So what does a binocular indirect ophthalmoscope consist of? And so I'm going to walk you through the instrumentation. And I think the challenge is to just get it right, put it on right, and actually see how it's done, because actually making sure the instrument is put on right, making sure the lighting is correct, then practicing it and positioning it yourself correctly with the patient is what's going to make you more successful. So essentially, the optical system is more on the front end of the binocular indirect ophthalmoscope. There is a rheostat for illuminating system, and we have to be very sensitive to it. It is a very bright illuminating system, very, very bright. And, you know, it'd be very important not to put it to the maximum illumination. You know, you've got to be quite sensitive to it. So you've got to keep it on a moderate illumination. And when you're doing the posterior pole, you have to dim it a little bit because it's a very bright light. And then in some cases, and I'll show you the advantage of a headband, the headband is actually what balances it for you, as opposed to a spectacle. So if you were ever to get a binocular indirect, the headband, I personally feel, is a little bit more balanced on the head. Okay. So what happens is the light from the binocular indirect comes from you. Okay. So you have two ocular pieces, so you can get depth perception, you get stereopsis. This is really important. The light goes through the patient's pupil, it bounces back, but in order to focus it, you have to use a condensing lens. So this is an additional lens we have to use. And there are different dioptric powers, which I'll show you. And it creates an inverted and reversed aerial image. And this just adds to a little bit of complexity to the whole thing. But when you have this aerial image, what you're looking at is inverted and reversed. And so you just got to remember that. But again, I'll show you some easy ways to think about it and how to go through that. But that's something that just is part of that instrumentation. Now, the condensing lenses come in different powers, and you could get a 20 diopter, 15, 30, 40, pan retinal. And I will say that most popular ones are 20 diopter. And if people could afford and need it, then they might get a 28 or a 30 diopter lens. The yellow filters were quite an item at one point because they said, oh, it'll just sort of calm the patients being very sensitive to the bright light and all that, but it actually changes some of the appearances of some of the lesions that normally appear whitish. And so it's lost its popularity. I think if we are sensitive to the illumination intensity, I think we're okay with that. So I'm not sure that that's absolutely necessary. So how is the formulas working? So let's say you get a 20 diopter lens and I get a 30 diopter and someone else gets a 15 diopter. How does it work? You can change the magnification effect and the field of view effect, what you're doing with the binocular indirect, based on the condensing lens power. And I'm sorry, my line, the line is not meant to be a canceling line, but sometimes the pen just goes funny and it makes that line unintentionally. Okay, so the magnification is approximately the power of the eye, and we're just going to make it 60 for sake of easy mathematics. And you divide it by the power of the condensing lens. So if my condensing lens is 20, then I'm going to get about 3 times magnification, okay? If I use a 15 diopter lens, then it's 60 divided by 15, and I'm going to get 4 times magnification. And then if I get 60 divided by a 30 diopter condensing lens, I'm going to get about a 2 times magnification. So it's actually an inverse relationship. So the higher the power of the condensing lens, the lower the magnification. So it's intuitively you think, oh, the higher the power of the condensing lens, the more magnification I get, but it's an inverse relation. And that's because of this actual formula. So if I use a 20 diopter lens and a 30 diopter lens on the same patient, I'm going to get a little bit more magnification with a 20 diopter lens versus a 30 diopter lens. And then we've got to think about the field of view. So if I have more magnification, I'm going to have less field of view. So greater the magnification, the less the field of view. And that's an inverse relationship, right? If I see more of something more magnified, I'm not going to get a large field of view. But if I see something that's large field of view, the magnification is going to be less. So it's almost like if I took a tree and I could see the whole tree, that would be my whole field of view, right? But if I could only see a branch with some leaves on it, that would be more magnified. So if I have more magnification, I have less field of view. If I have less magnification, I'm going to see the whole field of view, okay? So here it is in a summary table that if we had to compare a 20 diopter lens and a 15 diopter lens, a 15 diopter lens will have 4 times magnification. So therefore, less field of view than a 20. And the 20 diopter lens will have a little less magnification, but a greater field of view than 15 diopter lens. Now, there is what we call a 2.2 lens, and it's kind of neat because they actually designed the lens to do both aspects that you'd like. You want high mag and you want nice field of view. So they took the magnification equivalency of a 20 diopter lens and put it there. And they took the field of view of a 30 diopter lens because it had more area that it could see and combined it. And they created what they call a 2.2 lens, which is also called a pan-retinal lens. And ideally, fantastic, really good concept, but optically it's not as sharp as using just a plain 20 diopter or 30 diopter or 15 diopter lens. So it's important to just remember that, in my opinion, it's not doing it that way. So the question is, how do you know the exact approximate power of the eye with these lenses after seeing the fundus? No, so this is just a formula to just show you that if we use different condensing lenses, like if I have my binocular indirect, I cannot change the magnification on my instrument myself. The condensing lens, if I change the power of this, it ultimately affects how the magnification is on the retina that I'm viewing and the field of view. So it's just an approximation. It's using the power of the eye. It's a more complex formula than I'm telling you, but at the same time, I think it's just giving you an idea of how things are working, okay? And I will get to all these other questions that you have. So excellent questions, thank you. So here's just an idea of the field of view and the magnification effect. Here you have an optic nerve head, highly magnified. You can see the optic nerve head. You can see some of the blood vessels near it. And then here you have a field of view where you see not only the optic nerve head, you see the macula and you see the posterior pole. So the direct ophthalmoscope approximately, again, I'm making approximate numbers so that, everybody, it's going to vary a little bit depending on the power of the eye, power of, your refractive area and all, but approximately 2 disc diameters is what you get with a field of view with a direct ophthalmoscope, and you can get 15 times magnification. This is if you're emmetropic and if the patient is emmetropic, okay? Now, if I look at my patient same patient, if I use the binocular indirect, I will get almost maybe 3 2 to 3 times magnification depending on the condensing lens power, but I'm getting approximately 8 disc diameters of field of view. And this is important to remember. You get a bigger surface area, you get to see a lot more. The mag effect is a little bit less, okay? So here again, this is just, a diagram showing you that concept so that you actually understand that, there's a benefit for that. So I've put 2 pictures here side by side, just giving you an example of what it would be like if you did a binocular indirect, and what would it be like if you did, say, maybe a direct ophthalmoscope and got a little bit more magnification. So right here, you can actually see some hemorrhages, some blood vessel changes here. And so you get a picture that, oh, something's going on. And then if you look right here, you get a whole field of view. You get the optic nerve, you get the macula, and we're looking at this area here, which is translated up here. And here you can actually see, oh no, the hemorrhages are further out in the mid-periphery, and we got to take a look and pay attention to this. Here's another one. Here you can see some crossing changes, some vessel tortuosity, some hemorrhaging. And then if you look at this picture right here, while this area is right here in this area, you've got a whole feeling of something's going on with the optic nerve, something's going on in general with the whole vascular system. So the binocular indirect can actually do that for you. So when do we use the binocular indirect? When we've done a thorough routine ocular history assessment, a patient that comes in for a comprehensive eye exam, and again, I'm talking if you were legally allowed to dilate the pupils, we should do it. It's a routine dilated exam. And again, depending on the patient's age group, you may have to do it a little bit more often than not. So in the US, where I'm practicing, it's a standard of care, and it's an established standard of care. So as patients get older, some of the peripheral retinal diseases may be more often seen. We may have to see them more because of posterior pole changes. And so it varies, but at least once, or if not every couple of years, they should get a dilated exam, regardless of the age, okay? Patients who have retinal issues, okay? The big problem is vascular diseases. Diabetes is very, very common nowadays. And they absolutely show vascular changes, which really need to be monitored, minimum at an annual basis. Hypertension, there's vascular dysplasia, sickle cell anemia. There's so many other vascular diseases that need monitoring. And if someone has cardiovascular problems, they have carotid problems, well, we need to look for it. And sometimes we see it in the eye before the patient even knows they have the issue. If they have a history of blunt ocular trauma, if they've had injuries to the eye, they may be more prone to retinal tears, retinal detachments. If they've had previous retinal problems, and a history of that, then that should be really done routinely. And then another big thing is myopia. I mean, people are becoming more and more myopic, and 6 diopters or more is considered pathological myopia. And so they're at a higher risk of getting retinal detachments. The more myopic you get, it becomes the incrementally more important to check. And it's the peripheral retina that ends up being a site for retinal holes and retinal detachments. So this starts at a young age. We have to monitor these patients throughout their whole lifetime. And then is any pediatric patient that you're treating or you're looking at, or you're doing vision therapy, who has strabismus or has amblyopia, you need to do a dilated exam. You need to make sure that the fundus is clear without pathologies that may be giving the patient the strabismic finding or making the patient amblyopic. You have to look for things like retinoblastomas in young children. You've got to dilate the patients. So if you're monitoring pediatric patients, you're obligated to actually do a full dilated fundus exam and look at the peripheral retina. And then again, just remember the posterior pole is so important, right? You've got your optic nerve and macula, but things happen in the mid-periphery, things happen towards the ora serrata. Make sure we're looking at that. This is critical. And if you start seeing things, then you're monitoring them, or you're referring them, or you're intervening at a good time. So With the Binocular Indirect, you can get a spectacle mount and you could get a headband. And I would say the headband really is sort of more balanced on your head. The spectacle mount, while it looks very convenient and it's very portable, even these are very portable as well. It's front loaded, so it's all on your nose and it can get quite heavy if you put it on. Whereas this one, it's sort of balanced, it's weighted. So it's got a little bit of weight at the back and a little bit at the front, and it sits properly on your head. If you're in an office where people are using it, different people are using a Binocular Indirect, it can be easily adjusted. This one cannot be adjusted as easily. So I would say the headband is a little bit more of a popular one. As technology has improved, we used to have the battery one where we had to even plug into the wall. Then we had a portable battery one. And now we actually have, the wireless one where we have the lithium batteries that charge up. So here are the batteries that charge up, and you can actually just hang it on the wall, charge it for several hours, and then it's portable and you can take it from room to room. So that's the best aspect of it now. It's more portable. Before, you'd have to have a battery pack and plug in. They work equally well. It's just that they're less, you have to keep plugging it in, taking it out, plugging it in, taking out, or carry the battery pack with you. And that's, it's cumbersome. So when we look at the BIO, it's very, very important to keep the following. The pupillary distance has to match how you're putting the Binocular Indirect together, because you want stereopsis. So if you can get stereopsis, this is a really important aspect, okay? Binocularity. Looking at things in 3D is so important. If you get like a choroidal melanoma, choroidal nevus, you want to look and make sure it's flat, it's not elevated, you need stereopsis. Now, granted, people who can't get it, do your best. Light intensity, we're going to talk about that. The mirror adjustment for the light placement, we're going to talk about that. There's the filters, there's aperture sizes. Holding the condensing lens and examiner and patient position is all critical to the success of using a Binocular Indirect. Okay, so at the back, so this is the back end of the Binocular Indirect. Right here, there are two eyepieces. There's one here and there's one here. And you can see it right there. And the PD measurement has to be adjusted so that it matches your pupillary distance. If it doesn't, you're not going to get binocularity. You're going to get not good views. It's just not going to be comfortable for you. So you when you put it on your eye, so when you place it on here, you'll have a little adjusting to do to make sure the pupillary distance is matching your pupillary distance. And they can be adjusted, just moving your fingers along the back here, where I got my arrows, and adjusting the Binocular Indirect there. Light intensity resources are either on the battery pack or built in on the Binocular Indirect. And even now, as we speak, they're moving that technology even better and better. And again, it's very important that the rheostat is actually going to be adjusted so that it's not on its maximum intensity. It's sort of on a moderate intensity. Sometimes you have to increase the intensity if there's a dense media or pacification and you want to go right through it. You may have to, but I would always start at a moderate level. Be careful to lower it when you're actually looking at the posterior pole, because you're looking at the macular area and you don't want to blast that light so that it makes the patient very uncomfortable. Okay. Now, on the Binocular Indirect are some apertures. Okay, so these apertures come in different sizes. We have small, medium, large, and then we have a diffuser, which I'll talk about later. And this aperture size, if the pupil is well dilated, we can use a large aperture. Okay, if the pupil did not dilate very well, or you do it on an undilated patient, but they have a reasonably small size pupil, then you might want to reduce the aperture size to sort of match the pupillary size, okay? But with most dilated pupils, we just keep it on the maximum aperture size. So when you do that, the light that comes out of the Binocular Indirect will be round, and it'll be a whitish light, okay? Now we have filters on this side. These are levers that you just move and, adjust. And so you have like one which is a little pale yellow, then there's a blue filter, and then there's a red-free, or sometimes people say green, red-free filter. And they used to enhance the view of some of the findings that we look in the fundus. But normally we keep it on the white light, and we keep it on the large aperture size. Okay. Now, this is a very important thing. So you get your white light here. So, you put the binocular indirect, you adjust it, get your PD, you get this, I'll show you how to do the headbands. It projects a white light, which is kind of a circle. So it's got to be a proper circle. And when that circle area of light illuminates, which is coming out of this instrument right here, you can see the light coming out through there. Then you put your thumb in front of you. The light projects in front of you. So you keep your head straight, you're looking in primary gaze, the light's in front of you. If the light is down lower part of your thumb, you got to move this ball of light so that it illuminates the upper 1/3 of your thumb. So if this is my thumb right here, I want it to illuminate the upper 2/3 of my thumb, upper 2/3. Okay, so this is too low. And if that's the case, you're not going to be projecting a good view when you look in. Okay, all right. So the way you do that is you actually take this mirror placement adjustment here. You take this and you change it. And it moves this particular ball of light up or down. So this mirror adjustment is very, very critical to be successful. Okay, get the ball of light in front of you, put your thumb in front of you, and make sure it's in the upper 2/3 of your thumb. It's lighting it up. And you have to look straight ahead when you do that. Okay. Now, when you put the binocular indirect on your head, you've got to get the PD measurement. It's got to be aligned slightly lower or at the line of sight. A lot of people put the PD up, adjust it, but they put the eyepieces way up, so you're almost kind of looking up like that. No, it's got to be sort of on the line of your sight or slightly lower, because usually you're kind of looking down this way. And so make sure that that PD measurement and the alignment is very close to the eye. So make sure that this instrument isn't sitting way off, like it's not pushed outwards, it's kind of inwards. Another thing is the headband on the top and the band at the back has to be adjusted well. So it goes right on top right here, okay? And at the back, this is not really a good position. It shouldn't be here. If you feel the back of your head, it kind of dips down, okay? That's kind of where you should tighten it. So it almost slopes down a little bit, okay? So this diagram shows it well, but that back adjustment should be more where your head kind of bumps in at the back, towards the occipital lobe. So it should be a little bit further back. Having this adjustment really well done is important. You project the light, you see it, and make sure it shows it on the upper 2/3 of your thumb and that you have binocularity. Okay. The condensing lens has a white ring painted on it, and this should point towards the patient. It should point towards the patient. The more convex side faces you as the examiner, and the other side points towards the patient. So all the lenses that you buy, the condensing lenses, should have a little white ring or a gray ring on it. And so that should always point towards the patient. Now, let's say it points towards you as the examiner, you'll get more distortions. The view will not be as sharp, it'll get more distortions. So be careful with that. I think this concept is very, very important. And I think this is what brings the challenges, is that everything you do has to be aligned, okay? So you have your binocular indirect, you're putting the light right through the patient's pupil, and, so that's your pivot point. And now it's able to see the posterior pole. So everything is aligned, and you have your condensing lens right here. All has to be in a straight line. If the condensing lens is down here, your light's up here, you're just not going to get a good view, okay? Now, we have to rotate. This is the thing, this is the challenge with the binocular indirect. It cannot show you the whole retina in one view. You have to rotate. But when you rotate, you also have to keep everything in alignment. So if you move down, let's say, for example, you've got your binocular indirect, you've got your condensing lens, and then you're looking now at this part of the retina, the superior part of the retina, you actually are pivoting from the center of rotation, and that's actually helping you to see that, okay? All right. So this is just another artist diagram, just showing you that, you know, your light, your condensing lens, and your eye, the whole optical system is in a straight line. If you're moving, okay, or you're tilting or something, everything still needs to be in a straight line, and alignment has to be perfect. Otherwise, your views are not going to be very consistent. You're going to get a lot of shadows and things like that. Now, when you hold a condensing lens, this is the thing that I want you to remember. You have to have at least one finger near the patient's cheek or on the forehead or on the nose. You know, you have to tell the patient, you know, I'm going to put my fingers on your head. You're going to be touching this. I'm holding a lens in front of your eye. The lens is held very closely to the eye. Your arm is almost going to be stretched out. So you're going to be a nice distance away from the patient with your binocular indirect. But your condensing lens is going to be very close to the patient's eye. So we always may never float your fingers. If your fingers are not touching the patient's face and they're floating in space, you will not get a steady view. It will not work. I don't care how steady you are, it just doesn't work. So you have to hold the condensing lens like a letter C, got two fingers to hold it. And then the other fingers, you can use one finger, you could use three fingers, whatever pivots well for you. One has to be on the patient's face somewhere to sort of keep everything steady. And then you hold the lens close to the eye and you'll get a field of view. You'll get a view through the condensing lens. So let's say you get a condensing lens, you get a little view here, okay? And you'll see the conj here and then the rest of the eye here. So you'll get a red reflex and you'll see a little bit of the retina. And what you want to do is through your condensing lens is you want to fill up that view. I don't want to see the conjunctiva. I do not want to see the iris. I just want to see the retina. So in order to do that, you have to pull the condensing lens a little bit away from you. And that will fill up the lens. And it's called tromboning. Okay, so tromboning is this method where you're sort of, say if my hand is the patient's face, you're sort of holding the lens and you're pulling up and down. So it's almost like a little exercise that you're doing. So you're tromboning up and down. And this is important because it's going to fill up your view and you're going to be able to see more of the retina. So let me give you that example here. So you have your condensing lens close to the patient's eye. And this is critical. You need to, because you need to center this lens where the center of the pupil is, okay? So you don't want to just take a guess and just put it anywhere. You want to make sure it's close to the eye near the center of the pupil. Now, you get this view right here, okay? So you have a conjunctiva, you have your iris, and you see some of the fundus, which is great. But I want to fill this whole condensing view with the view of the fundus. I don't want to see the iris and the conjunctiva. That's, to begin with, is where I want to be at, and then I want to improve on it. So then what you do is you move the lens a little bit further back. And again, it might be a few millimeters, it might be a few centimeters. It just depends, right, on where you start out with. And then it fills up the whole condensing lens with the fundus view. So here is what you're going to do. You put your binocular indirect on. You have the patient look in a certain position, which I'm going to get to in a few minutes. And then you get a red reflex, okay? So you see the red reflex, and that's good. Look for it. Now, in some people, it's going to be very dim in color because we have more pigment in our fundus. In some, it's going to be brighter. So you find the red reflex. You tell the patient, keep looking where you are. You don't move your head. You don't move your eyepieces. You keep steady. You stretch your arm, and you pop we say pop it, but we put the lens, the condensing lens in front of that pupil that's dilated. And you can see exactly what I mean by here, okay? I see the conjunctiva, I see the iris, and I see the posterior pole. Right, that's great, I've got a view. But I want to fill this fundus view with the entire condensing lens. And now I'm going to pull the lens towards me so it fills up. And now you can see it's actually filled up. It's not the same patient. So that's a trick, okay? It's not the same patient. This is just a different patient, but it just shows you get a full view. And that's what your goal is, okay? So another thing is reflections. Sometimes you get a little bit of reflections and we can tip the lens a little bit. We can tilt it a little bit to get rid of the reflections. Another big hint when you're learning to do binocular indirect, it's not a hard and fast rule. It's not like I use it now and say, oh, I'm going to think about it. But when I'm teaching someone, I tell them that in your condensing lens, you're going to get 2 Purkinje images. You're going to get 2 Purkinje images. And those images, if we kind of tilt the lens slightly, and it might mean a little right to left or up or down, when those 2 Purkinje images get close together, they don't have to, they can sometimes overlap or sometimes come very close together. Then you're holding the lens at the right angle, okay? And then if it doesn't fill your view up, if it's not filling up your view, you tilt the lens a little bit, you clear the angle for you that you're holding it, and then pull the lens up and you get a full view. Now, you might argue with me and say, this is a full view and these 2 Purkinje images are not together. That's okay, they got a full view and they've been able to do it. But when you're learning, using the Purkinje images to slightly tilt the lens in the right way to then fill up your view by tromboning the lens towards you would be actually very critical and very important. Okay, so we're ready for our second question, and you type in the chat. What is the technique called when you're attempting to fill the view in the 20 diopter condensing lens? Or what do you do to help fill the view in your 20 diopter lens if you get just a bit of the iris and the conjunctiva and you only get a little bit of the fundus? What do you do? Type it in the chat.
Okay, so we are getting some answers, and yeah, I think most of them are saying it right, I guess.
Yeah, it's tromboning.
Tromboning.
And also, and if you couldn't remember the word, is basically you're going to start close to the eye, pull the condensing lens a little bit away from the patient, and you're going to be able to fill up the lens. Very good. Okay. Now, in some binocular indirects, they have what we call a small pupil feature or converging system, and you can put it at a different converging system. So here you can actually see that the system, the optical system, is a little bit further apart. If the patient is dilated, you can put it on the maximum setting, where it doesn't have to be converged. But if the patient's pupil is not very well dilated or it's smaller than usual, you can converge the system. And all it does is brings the optical system in. But be careful, if the patient is well dilated, you're not going to converge the system. You're going to just leave it at where it is, which is here, okay? There are teaching mirrors. So for educators or for someone who you're watching, you can put the teaching mirrors and you can actually see the view. Very important, when you use a teaching mirror, dilated pupil, you have to put it so that it's not converging like this. You've got to put it more like this. Otherwise, you're just not going to get a good view from the teaching perspective. This is another instrument where they don't have that converging system. Not a big deal. It's just a little added feature. Here they have a teaching mirror. They put it in so you can watch and see what you're doing. They also have a magnifier that brings in a little bit more of magnification effect. So most importantly is how do I examine and how do I obtain views with the binocular indirect? And this will answer some of your questions that you've been kindly asking in the chat. So actually, you're going to view 8 peripheral positions, and then you're going to examine the posterior pole. And unfortunately, the instrument doesn't allow you to see the fundus all at once. It only gives you a small sector of the fundus, and then you've got to overlap your views and then get to the posterior pole. So what you'll do is, where it says number 1, that's going to let you see the superior peripheral retina. 2 is, let's say this is the nasal side and this is the temporal. This would be superior nasal, inferior nasal, inferior temporal, and superior temporal. So you're going around and you kind of go in a clockwise fashion, or you can go in anti-clockwise. It doesn't matter which way you go in your flow, okay? Depends, but you have to be consistent. So if you want to go anti-clockwise, fine. You want to go clockwise, that's fine. But you just got to maintain a flow throughout the whole eye examination. The posterior pole, you're looking more at the center. This is how I train, and this is where I think sometimes we miss some of the pathologies, is in the sort of that mid-periphery. So I also have them do 4 other views sort of the posterior pole, and I'll explain how I do that. Okay, now some practitioners will just do 1 in the center because they're just so good at it, and then they'll do 8 views in the periphery. Okay, so this is where it gets a little tricky, and this is where people get a little tripped up. So if the patient is looking up, okay, so their pupil is dilated and they're looking up, right? What you're going to do is you're examining the superior retina. I'm just going to say superior peripheral retina. So anatomically, I am looking at the superior fundus or retina, whatever you want to call it, when the patient is looking up, okay? Now I'm the doctor and I'm sitting here. This is me up here with my binocular indirect. And in order for me to get a view of the superior retina, I have to be inferior to the patient's position. So the doctor has to be 180 degrees approximately away from the patient and the patient's pupil. Okay. So if the patient's looking up, you sort of got to be down. Okay. You got to be lower down. Now, you project your light, right? So you have your binocular indirect, you project the light, you hold your condensing lens here, and now you're looking at the superior retina, okay? So when I document whatever I found up there, okay, so this is my optic nerve and macula, whatever it is, I am going to document my findings superiorly. That's just how it is. So we're going to document it superiorly. Okay, now I'm going to go to the next one. I want to look, say, at the temporal retina. Okay, so the patient is looking temporally, so the eye is more temporal. I'm going to be at eye level with the patient, but I have to be more nasal. Okay, so if the patient is looking more temporal, I'm going to have to be more nasal. Okay, so I project my light, I hold my condensing lens, and I get a view in the temporal retina. So I am going to document this finding in the temporal retina. Okay, so this is nasal, superior, and inferior. So I'm going to always, as an examiner, be right opposite the patient's pupillary gaze, where I want to examine the patient at. Okay, let's look at this one. Let's say I want to do inferior nasal. Okay, so this is the nasal retina, this is the temporal retina. Right? So the patient is looking down, right? And then towards their nose. You have to be sort of up and temporal. Okay? Now you might imagine that and say, how's that going to be? But it will happen. Okay. So a lot of times we will do binocular indirect, if possible, laying down, the patient laying down. So it's easy for you to rotate around the patient. So if the patient is looking inferior temporal, you're going to be superior temporal. So you're going to be opposite that. You direct your light, your condensing lens is here, and that's what I get. And on paper, I'm going to document my findings inferior nasal. Okay. So you as a practitioner have to be sort of opposite of where the patient is. Now, the posterior pole, the patient is looking straight, right? The patient's looking straight. You're going to be at eye level and looking straight at the patient. So it's like 2 people sitting across each other on a table. You're going to be just like that. And in order to do the posterior pole view, you could do a number of things. You can have them look at the top of your head, to your right shoulder, to your left shoulder, and to your neck. And you'll get overlapping views of the posterior pole and part of the little bit of the mid-periphery. And that assures you that you've done a really thorough posterior pole examination. But as you get really good at it, sometimes they'll just say, all right, just look at my ear right here, or look at my shoulder here, and they get a full view of the posterior pole. But here, you're going to be literally eye level, and the patient's looking straight ahead in primary gaze, okay? So when you're doing peripheral views, the patient's looking in secondary gaze, either up and to the right, up and to the left, left, right, down and the right, down and to the left. That's exactly how you're positioning the patient for that. Okay, now we're going to talk about the following. So here I've just tried to artist diagram it. If the patient is you want to look at the inferior view here, and let's say it's down here, you've got to be sort of more superior, right? If you want to look at the posterior pole view, you've got to be more at eye level. If you want to look at a superior view, you've got to be a little bit more inferior. So you've got to always be 180 degrees away from the patient to project what you're looking at, all right? Okay. Now, how do I document? Because I told you that the view is an aerial view, and that can be sometimes confusing. So what you see in your condensing lens, inside your condensing lens, is going to be reversed and inverted. So it's going to be reversed and inverted. But in real life, you've got to flip it and just draw it the way it should be. So I'll give you an example here, and I'll explain this. So when we document our findings in Binocular Indirect, think of it like a lotus flower, and now I'm peeling each petal back. So the first line up here, okay, up here is the equator. The second line is the ora serrata. And the third one, I wouldn't worry about. That's the pars plana. We just don't want to think about that. The equatorial line, right, is this dotted line. It's going to represent this line here, which is this line there. And then the ora serrata is further out, and that would be this line here, and that would be down here, right there. So on paper, we're going from 3D to 2D. And so we've got to draw what we find. And so we do it by clock hours. So we've got 12 o'clock, 1 o'clock, 2 o'clock, all the way around to 11 o'clock. We have clock hours. And our reference points are the posterior pole, like optic nerve and the macula. We have the equator and the ora serrata, and then the pars plana. So we've got 3 circles. So let's say I see something superior retina near the vortex veins. I'm just going to draw it superiorly near the vortex vein. I might shade it in, and I might label it, and I'll maybe talk about the size. That's how I document my findings. Now, the question is that upside down and reversed concept, right? My patient is looking up. Patient is looking up, okay? So therefore, I am examining the superior retina, okay? And I'm going to document it in the superior retina. So on that diagram right here, I'm going to document it in the superior retina. Now I have to find some landmarks to tell me, is it near the ora or is it near the equator? But I'm going to document it in the superior retina. Now, in my condensing lens, while I'm looking at the patient in the superior retina, I see, I've drawn for fun, a circle and a line. That's what I see in my condensing lens. Okay. I'm going to document that in the superior retina, but I'm going to invert it and invert it, like make it upside down and revert it. And so the circle's going to be down and the line is going to be up. So that's what I'm going to do here. So for example, if this was a retinal hole and there was a tear right here, right? And I see that in my condensing lens. It's still in the superior retina. It's just flipped over. Actually, the hole is here in the tear. It's just relative to those findings, okay? A very nice example would be the posterior pole. If I look at the posterior pole, the patient's looking straight ahead. I put my lens in front of the eye and I see this. I see the optic nerve, I see the macula, and I see a hemorrhage, a little red dot. I'm going to document it where? I'm going to document it in the posterior pole because that's where I'm looking. The patient's looking straight ahead. I am going to document it in the posterior pole right here. Now I say to myself, oh, I saw the macula. Well, the macula is going to be more temporally in real life than optic nerve, which is more nasal to it. And this hemorrhage, which I saw underneath the disc, is going to be superior. And so this is a dot and blanc hemorrhage. that's superior to the optic nerve head. And that's how it's going to be. Because if I told you to take a direct ophthalmoscope and you go in, the hemorrhage is not going to be inferior to the optic nerve head, it's going to be superior. And that's how it is. So wherever you're looking at, just remember, wherever you're looking at, whatever you've seen, it's where it is. So if I'm looking at the superior retina of the individual, I'm going to document on the superior retina. I'm going to use my landmarks to tell me exactly where it is or what clock hour. And whatever I see in my condensing lens, it's inverted and reversed. And then you make that change on your paper. So hopefully you got that concept. It's not that difficult. If you just keep in mind wherever you're looking is wherever it is. Now, this is from someone who's doing the binocular indirect. Your arm is going to be very stretched. You're going to hold the condensing lens and you can see they're pivoting the lens with their fingers on the patient's forehead. This is very important. It might be on the nose, might be on the cheek, okay? And it's all in a straight line optical view when they're looking. And you can see the distance between the eye and the condensing lens is a little bit shorter than your arm to the binocular indirect, okay? When you change position, remember the optical setup has to continuously be a straight line. Otherwise, you're not going to get a very good view. So with binocular indirect ophthalmoscope, your view is inverted and reversed. Your mag effect on average is between 2-3 times. It's variable depending on the condensing lens. You get about 8 disc diameters of view at one go, about 40 to 45 degrees. The pupil should be dilated, although you could try it with an undilated pupil, but the pupil has to be at least 4 or 5 millimeters, hopefully. You get excellent stereopsis. Resolution is very good. You don't have to work too close to the patient. You know, like your face is not really into the patient, it's arm's length. And does media evaluation. Can you actually examine the effect of the media with the binocular indirect? And I want to explain that concept. Say someone comes in with a dense cataract like this, and you do a direct ophthalmoscope, you may get a very blurry view of the optic nerve head, or you may not even really see it. The binocular indirect, the optics of it kind of bypasses media opacities to some extent, not to all extent, but to some extent. And you can get sometimes quite decent views of an optic nerve head or a macula if you're looking at that. If it's a very, very mature cataract, it becomes difficult to get really good views, but it doesn't give you the real perspective of how the media has affected the vision. Direct ophthalmoscope can, whereas BIO, sometimes when it's like a mild or moderate cataract, it can kind of bypass it and you can actually see the retina pretty decently. So it doesn't give us a visualization of how the effect of the VA is going to be if there's a media opacity, but it does allow us to go kind of through that. So that kind of brings me to the end of my presentation. It's just an overview and it's just the beginning of how to do binocular indirect. I can take some questions if you like, if I have some time. So Fakhruddin, will you tell me if I have some time?
Sure. So first of all, I think thank you so much, ma'am, for that detailed presentation. I think you covered every aspect from the technique and then, instrumentation, and also the most important where people do get confused, as you mentioned, is the recording. What we see is reversed and, laterally reversed it upside down. So thank you so much, first of all, for doing that for us.
You're welcome.
Yeah, great. Okay. One of the questions which came in, I think that's important as well, because we did talk about examining patients and you also talked about the various patients' criteria, who you should be looking at. One question which arises is, do you do something differently or give any tips for us if you have a pediatric patient? Is there something different or something which we should be aware as clinicians if we are looking at a pediatric patient?
Yeah, I think pediatric patients are not always easy to examine because sometimes they're less steadier and, but any pediatric patient that you are going to prescribe glasses for, whether it's myopia, whether it's hyperopia, whether it's for preventing amblyopia, whether it's like, oh, they have a strabismus, let me just check. Is the strabismus from a muscle dystrophy, or is it from, or is it some retinal finding that's causing, the eye to sort of shift and the muscles to change and all that? Then you need to do a binocular indirect, okay? Now, it's challenging because sometimes the child's wriggling around and things like that, and you do your best. But the fact that you document it and that you attempted it and say, sometimes you might say fleeting views of the peripheral retina appear within normal limits or something. At least sometimes if we document it in that way, then we're covering our bases as well, right? So I think it's important. The other thing is, which I didn't really emphasize, because I think when you have to do it in person to really feel the binocular indirect.
Yeah.
Try to, if possible, and again, not all chairs lay down, but if you were to get a chair ever in a practice, make sure it's like a dental chair. Make sure it lays flat. It's much easier for you to rotate around the patient. So if the patient is flat, patient is looking up, you can be kind of towards the patient's feet, right? And then just project close to them. If the patient is looking down, you can be at the patient's head, So imagine a young child, if you could kind of lay them down a little bit, you have a little more control on how you're moving, and then you could direct them. And so you could snap your fingers and say, look here, or flash a light here and say, look here, and even people who are very myopic, some people will just say, look here, and they can't even see your finger. You might tap on the head and say, can you look in this direction? Can you look up here for me? Can you look up and right? And people get confused, right and left, right? So you just say, where my finger's tapping, can you look in that direction? And that would help. With PEDS patients, maybe you have to have a little light, to sort of entice them to look in different directions. Holding the lids is also critical in the exam, because sometimes when the patient's looking down, the lid's coming down, you've got to have to retract it. When you're doing temporal and nasal views, you've got to have to use your fingers to open up the lids, because sometimes when the pupil's way out in the corner, it's kind of harder. And again, using those little cues and helps will actually help the patient with your views. But you do your best, because sometimes it's very hard. There's some children who have ADHD and they're jumping around and they're just difficult. But you'd say we attempted. We did not appear to see any abnormalities, and then have them back again. Yeah, so there are challenges. But again, it takes a trained binocular indirect examiner to be quick with it and, relatively fast. And again, it takes a long time to actually become very comfortable with it. Yeah.
That's right. Yeah. So I think a couple of very important points. I think even as optometrists, we also sometimes forget right and left. So the tapping method was very useful for a lot of our patients. It's like to direct them where to see and to look at what the direction of gaze should be. So you are aware where they are looking, and that it minimizes the confusion of recording then later, right?
Mm-hmm, mm-hmm. Absolutely. And if you develop a routine and you follow your routine with whichever way you want, clockwise, anti-clockwise, right eye first, left eye, whatever routine you develop, that's critical, because then, you're just like, oh, did I forget to look at this? And it becomes second nature as well. And then also someone asked, if you're a very high myope, does it really affect the power on the BIO? It's negligible. We don't really see that we don't see a stark difference, this wasn't so myopic, my views are different. No, I think it's not a stark difference, it's a subtle difference. And then the question is, if you have someone with Marfan syndrome and a subluxated lens, it's going to be a little more challenging to see it. That I think would affect how you hold the lens and how you go through the lens. And again, with patients who have subluxated lenses, you've got to be careful when you don't to dilate them, because sometimes if the zonules are weak, you can actually do more harm than good, right? So be careful with those subluxated lenses and dilated lenses. But if you were to view it, you will get views in through the lens, but through part of the lens, it might be really just very obscured. It's going to be challenging, definitely.
Right. And just one question which came up here. how much of a normal pupil size do you recommend to do? Is there any recommended number that we must have a pupil size of, let's say 3 mm? It's good enough, or?
Yeah, 3 mm is challenging. I think 3 mm is challenging. You would get to the equator. I think aura would be very tough.
Yeah.
I think 5-6 millimeters is good. Anything bigger than that is a present. It's good. Because remember, as you age also, some people's pupils don't dilate as well. And if you're diabetic, also your pupils don't dilate as well. So you may have to work with a 5-6 millimeter pupil. Younger people, 8 millimeter, 9 is fantastic, and you get good. So if you're training and you're learning, start on your younger patients. So you develop the muscle memory. The problem with binocular indirect is the muscle memory. How far should I hold my hand? How should I hold my lens? How should I avoid my fingers getting in my way? If you develop the muscle memory for that, and your technique is down, then you start to help. It helps you to start now seeing what's norm in the retina. It's quite boring, actually. It's not like, oof, that's the optic nerve and a macula. It's just red, right? And it's got vessels, and you're like, I don't see anything. What's this, And then over time, you start to pick up the subtleties. And then when things start to show up, then you're like, oh, okay, there's something here. Yeah.
Yeah, right. And I think the pupil size question popped in because the attendee wants to know, is it better if I do it in a dim illuminated, or if I do dark adaptation to my patient prior to doing the test? Would that help compared to not dilating a patient? Something like
right. That. So if you are in a circumstances where if you can dilate the patient, yes. Fine. We still keep the room illumination very dim. Not so, like students like to have it completely black out, but then if you trip over, something on the floor or whatever, keep little light. But sometimes, it kind of creates a reflection or something. So we do dim the lights for that, no question. If it's an undilated pupil, like you're attempting and you're doing a converging system with the binocular indirect, then I would suggest that, yes, having a dim light and having the patient a little dark adapted. But remember, the binocular indirect light is very bright. Yeah. It is extremely bright. So you can dim it as dim as you can, but sometimes when you dim it to so little, you barely can see anything. So you're going to have to make it brighter. And if you have a darker fundus, you're going to have to make it a little brighter. If you have a very light fundus, yeah, I can dim it to quite a bit and still see. But when you have a darkly pigmented fundus, you're going to have to increase the light, and that automatically is going to constrict the pupil. So really pre-prepping the patient before in the darkness, it helps a little bit, but as soon as you put the light in, pupil's going to constrict. So there's a challenge with that. But sometimes if you have a converging system on the binocular indirect, could help a little bit with the light scattering, so it can kind of bring it in a little bit more. That would be helpful.
That would be helpful. Okay, I'll take one last question. This is just coming up on my chat. That's why you're not seeing on the screen. But this says that I am a new student. I want to, start practicing BIO when I graduate. What is your choice of lens diopter which I should start if I'm a beginner? Should I start with a 20D or should I start directly with a 30D?
We all start with a 20 diopter lens. We all do. We teach the students and they all get 20 diopter lenses. The exception for a 28 diopter lens is if you're got very small hands and very short fingers, and it happens, sometimes it's very hard to pull the lens out a little bit, and your length of the body also. So the taller you are, the longer the fingers, the easier the time you have with these lenses. But I don't have big hands and I don't have long fingers, and I manage very comfortably with the 20. But on occasion, we do find someone who's really struggling that a 28 diopter lens can help. But I would say that's pretty rare. So I would say go with the 20 diopter lens. And then later on, people who do a lot of binocular indirect will probably get a 28 diopter lens. Yeah.
Okay, great. So that's really, helpful because we do have a lot of students. So I think that comes from one of the students that, let's say I want to start, what should I do? And 20 is what everybody, I think, learned, and 28 and 40 is probably rare cases, as you said, short arms and something.
It is, and it's sort of a gift, right? If you have that, right? And then also when you start practicing, you can use a schematic eye, or you can make a box with a little hole in it and put a +6 lens in it, and use your box to sort of get used to how you manage using the binocular indirect. So we always try to do that because we don't want to burn the eye with the bright light and I don't know what I'm doing. So we try to do a simulated version. There are very expensive simulators, unbelievably expensive. Yeah. So a box is fine. So you create a little box, right? And you have a little hole in it, put a +6. It's probably about 3 or 4 centimeters high. And then you can use the box to put the light in and kind of look at like the paper I showed you with the rings in it. And you're sort of seeing, like, can I get out there? Can I see it? And then you translate it to the eye. Yeah.
That's right. Yeah. Mm-hmm. So I think with that, we have taken most of the questions. And with that, thank you so much, ma'am, for that wonderful talk and, sharing all that experience and also the details about each and every step of BIO. Thank you so much for doing that for us.
Oh, you're welcome. Yeah.
We do have session planned next. Until then, take care, be safe, and I hope to see you in the next session. Bye-bye. Thank you, ma'am. Have a good day.
Thank you. Thank you so much. Have a nice evening. Sorry it's late for you.
No problem. No problem. It was very nice and informative. So we can just keep on going. Yeah.
Okay. All right. Have a rest of a good week, huh? Okay.
You too.
Thank you. Yeah. Okay. Bye. Thank you, everyone. Thank you for your time. Thank you for your patience, and thank you for your comments.